there's a small group, so just ask questions, but I'll ask questions to start. You want to tell your background, what got you into addiction
Sure.
medicine?
So my name is Ken Starr. I grew up in El Paso, Texas. It's not the end of the earth, but you can see it from there. And I went to Boulder for college. I came back to Texas for med school residency in emergency medicine. I was in Eugene, Oregon for 10 years. And then my wife, who's from California, said, we're not living here anymore. So she wanted to be in St. Louis because she had been here years ago when she was in college. So I moved it here, just sight unseen pretty much. I said, wow, what's that yellow ball in the sun, that yellow ball in the sky that creates heat? So we've been here since 2010 and worked full-time doing emergency medicine with the group that does Sierra Vista in Twin Cities. And then, but over the years in doing emergency medicine, we constantly deal with drug and alcohol problems. The consequences, lay consequences, overdoses, alcohol intoxication. I mean, if there were no cigarettes or alcohol, I wouldn't have a job in emergency medicine.
Yeah,
literally, it's such a
one of us would be out of a job, certainly.
Yeah, I mean, the volume would be, I mean, there's so many downstream consequences of that. So I'd always kind of been interested in it. And I have a friend, my best friend is actually an addiction psychiatrist in Portland. And so we hang out all the time. And over the years, I just kind of got really interested in what he was doing. It's like, well, you know, I'm not trained in psychiatry at all. And except for growing up in my family, you kind of learn a little bit about psychiatry. So anyway, so I kind of got a sense of what he was doing with like medication-assisted treatment and buprenorphine and outpatient alcohol detox. And I thought, oh, I can do that. I mean, I'm doing that every day. And of course, here at the time, there really wasn't anyone doing it at all. Not doing it well. I mean, you got a county program, you got a couple family practice, maybe docs sort of dabbling, but you didn't really have any sort of board certified full-time addiction medicine practice. Outpatient, affordable, I mean, really bring it to the people. So I kind of started dabbling in that a little bit. I thought, well, I can do this. So I rented like a little office that was, you know, inside someone else's office, which was inside someone else's office. And then my brother overdosed on heroin, who, you know, he had a whole lifetime of, you know, of drug problems. So I thought, this needs to be like a real thing. So I was just me, and then that just got busier, and just as it grew, just organically, you know, then I kind of met a lady named Juliana Backett, who was a drug and alcohol counselor, who thought, hey, we could do this, like, because you're doing medication, you're doing this management, detox, but they need a program. These people all need a program. So I kind of teamed up with her. We started this program where I would do medication at the end of it, and she would do the groups and facilitate therapies, and it was great. And then we took it from a bigger office, and we were in Los Osos for most of the time. And then January of last year, we moved the program into AG, into downtown the Village, where we have a nice 4,000 square foot building. So, and then as we kind of grew, we were pretty ghetto when we started, just taking care of people and just figuring it out. But as I learned, you really, unlike what Sam does, you really have to do the insurance game to make any money in what we're doing. Like, it's not sustainable if you're not in the insurance market for what I do. Because there's not a lot of people who are going to self-pay for treatment, especially people who've already paid for insurance. It's like, I pay all this money for insurance, I really want to find a program that takes my insurance, which is, I get that. So I'd rather go out of town than out of pocket. So we can take care of you, but you know, it's $4,000 for 12 weeks, it's like, oh no, let's forget it. So in November of last year, I brought on a really talented senior administrator named Julia Jackson, who's just the most amazing person I've ever met in my life, who in that time got us state certified, got us CARF accredited, redid all of our policies and procedures, redid all our HR, our employee health. I mean, I could never do that, right? You always hire people who do stuff you could never do. So now that we're state licensed, we're CARF accredited, which is sort of an external validation of how, like, you have a legit program. Now we can really play that insurance game, which is, I'm not happy to do it all, but we need to. And our programs have grown. So we primarily do, I was telling Deborah, we primarily do drug and alcohol. That's 90% of what we do is drug and alcohol, substance abuse. And then about a year ago, we already had an infusion nurse and team there because we're doing detox. So I already had people there all day with IVs, and I'm detoxing them and taking good care of them. So I thought, we can do like more with this, right? So I teamed up with a really talented nurse named Debbie Kalinsky, who is an expert in nutritional medicine. She's like, oh, you can just bring people in and give them vitamin bags. They love it. They feel great. Oh, really? Oh, yeah. We have a skinny shot. We have this immunity booster. Here's some naturopathic solutions intravenously that will, cure the cold. We can do high-dose vitamin C. We can work with cancer patients. Wow, cool. So then I really started getting involved in like nutritional medicine and doing all that, and it's relatively easy compared to drug and alcohol, So that's so I'd say that's probably like 10% of what we do now.
So those are patients who do not deal with addiction issues?
Yeah, right.
They just come in, they say, I'd like an infusion.
Right.
And you have a menu of sorts?
So we do now. So actually we have, bringing that full circle, so now we have a nutritionist, we have a naturopathic physician who run and manage programs that like I'm not super familiar with because it's not my wheelhouse, but we offer that and they're really experts in what they do. And they have really amazing programs like hormone-assisted weight loss and really powerful tools that I sort of sign off on them and make sure medically I think it's okay. And so, so we have a lot of patients now who are not addiction or substance use patients who are coming in for weight loss, for hormone replacement, women's hormone, perimenopausal stuff, which, not touching that.
So what is the edge of what you will do? I mean, someone comes in with a UTI, are you treating them?
My existing drug and alcohol patients who have an acute concern like pneumonia or UTI, I take care of that.
Okay.
But if just a patient called and they needed, primary care, we're not in that market.
Okay, so you'll tell them, no, you should go to MedStop or call Sam.
Yeah, pretty much. I'd say, go to the ER, go to urgent care, or call you or something for general stuff.
Yeah.
But things come up in our existing patients. Yeah. If it's already an existing patient in some capacity, can you check that? Can you look at this? Sure, they're already there, but we don't really advertise ourselves as primary care. But the reality is that, patients with addiction have been totally disenfranchised from the healthcare system. Once you tell your primary care doctor that you've been abusing those medicines and you're really taking that whole prescription in 3 days and buying the rest of the month worth on the street, they're not going to prescribe for you anymore. And doctors don't want to deal with substance use patients because they are manipulative, they're dishonest, and it's the behaviors that have had to develop to manage that disease. So you have this huge amount, including discrimination by ER docs, so once they're drug seeking and out of my ER, right, we deal with that. So you really have this huge amount of patients who are disenfranchised with substance use problems who can't get help if they wanted it. So we have found a niche by saying, you know what, I enjoy doing this, I'll take good care of them, have them come see me. And they're so grateful.
How do you get them in there? I'd love to
well,
to go to a place like
yeah, well, I mean, obviously,
how do we get them
well, they have to be ready. I mean, ours is all voluntary outpatient. So my patients come in thirsty for solutions, like, help me. Here's what I'm doing. I can't do it anymore. That's like a captive blank slate. They'll do anything there, and they do great. We still have parents drag in their adult children who, like, I don't have a problem. I don't need to be here. Yeah, well then, that's fine. Call me.
It's outpatient only that you're dealing with, right? Like you're
yeah, so I
detoxing someone in a 24-hour detox type thing, or just
well, no, I mean, our detox program, actually, the detox program I really like to do is actually 10 days.
So what do you do?
Well, we have different levels of care, but going back to that, so yeah, if patients aren't ready for recovery, then they don't, It's like if a mom calls and says, yeah, I have a 42-year-old son he's drinking, he's taking pills, and I want him to come in, what I say? Have him call me.
Yeah.
I'd love to talk to him. So, that's just nothing I can do about that. But when people are ready, then there's a place now that they can go and get help, and we can do.
That's one of the most frustrating things in the emergency department is that you have people who, often they show up intoxicated and then they're better and then they just drift out back into the wilderness. But sometimes they want help and the options are very few. We can say public health. I give Ken Starr's name all the time.
I get patients from the ER. Hey, I was in the ER and they gave me your number.
Yeah, when someone wants help, I feel like that is, that's the best moment.
I think that's the hardest thing, is to get someone, you really could use help. I mean, there's so many functional alcoholics, functional Vicodin, Norco users, that kind of thing. I've got a sister who's totally, not really, I would not say 100% functional, but she,
But they also don't see it.
Every single day,
right.
drinks with it, all this stuff to alleviate her pain. So it's a pain management thing. So she thinks that's the only way out of this.
Right.
And I've seen her destroy herself in the last 10 years. And her doctor just keeps prescribing that every 30 days.
So that's a big cultural change now. So now with the scrutiny on primary care doctors, with the opiate epidemic, the FDA and the state medical boards have really said, you really can't be giving this patient 180 pain pills every month. It's like if they're over this amount of medicine, if they're over this many morphine equivalents, or if they're going to be on pain medicines for longer than this period of time, we are actually going to require you to send them to a pain specialist. You know what? Primary care doctors like it. Hey, we're going to send you to pain management now. But guess what? They go to pain management and they're like sitting around with like, oh my God, I don't want to be here, So we get a lot of refugees from pain management in our clinic too, but yeah, that's part of it. But that's been a big shift. Norco or Vicodin went from a Schedule 3 to a Schedule 2. It's harder to prescribe. Doctors don't want to deal with that now. So we'll get referrals just from patients who I have a regular doctor. They take care of my high blood pressure, my diabetes, but I'm on these pain medicines. They don't want to give them to me anymore. So I say, is your pain controlled? If they say, yeah, my pain's controlled, and I say, okay, well, do you want to get off the pain medicines? Because if they just want someone to prescribe pain medicines, that's not me. I'm not pain management. We're recovery oriented. So if their goal, and I always say, what's your goal? If your goal is to just, hey, these pain medicines are working, I have those patients. No, my pain medicines are working. I just want to stay on my pain medicine. That's fine, but we'll send you to pain management and they'll just write your prescriptions. So it's just kind of sitting down and getting to know, but like, what's your goal? What do you want? But I've had some really crazy cases, over the years of different types of people. So anyway, that's in summary. To answer your question, that's kind of what we do at the program now.
But I think
patients who you're saying sometimes when they're detoxing, they're coming back for a 10-day program, so they're coming back to you every day.
Yeah, so I've been, up until this last week, I was actually the medical director for the residential program here in town called The Haven, which is a private program. So I've been their medical director and I helped get them started. As of last week, I resigned, so I'm not really affiliated with them anymore, but that was an inpatient detox, which I would manage. My program is all outpatient, but having had both sides of it, I can tell you that as long as somebody has some support and some structure in their life and a place to live, I can get way better results doing an outpatient program than they get doing a foo-foo expensive program for 10 times the cost. And the reality is that most medicines used for detox hasn't changed in 30 or 40 years.
Well, Suboxone is the big
just for detox
changer.
So what are you doing? I'm just curious.
Well, so we use some general standard of care stuff that your typical alcohol detox over the years has been benzos or phenobarb. That's, and that's what I was going to say. You could go to Passages in Malibu or Hazleton and spend $60,000, but you're getting the same $3 in medicine that you're going to get at the county for the exact same thing. So we use some real alternative things too. So to branch aside, so we can do just regular detox. It really kind of depends on where people are and what they can afford and coming up with a plan that's going to be successful, because some of the programs I really like are more expensive. So one of the things that we use, which Deborah might be interested in, is a substance called NAD. So NAD is a naturally occurring coenzyme. It's called nicotinamide adenine dinucleotide. This is a natural, this is a cofactor that your body uses for over 400 chemical processes that you need to generate ATP. Your mitochondria cell crank out NAD to make ATP, to make energy. So this is sort of the engine that you need to make energy. So it was discovered a long time ago, about 1939, that the metabolism of alcohol and other drugs actually is NAD dependent. So if you're even a moderate or heavy drinker, you are NAD deficient. Because if you look at the metabolism of alcohol, you use 2 molecules of NAD to metabolize alcohol. So what they've kind of put together is that if you are NAD deficient, and now they've learned over the last 20 years that NAD is this key step for these enzyme complexes that repair DNA and that control transcription of DNA and that control inflammation. So people who are drinking and drugging have a very high inflammatory state and a high level of oxidative stress. This is what you can measure. And you measure things like 8-isoprostane, tumor necrosis factor, and some other things. And as people go through withdrawal, that even gets higher. Now, once they're detoxed and they feel better, those levels go down. Your body can make NAD. You can restore it, but that's why it takes a long time to feel better. So anyway, in the 40s and especially through the 60s, in other parts of the world, especially South Africa, scientists learned that if you gave high-dose pure NAD intravenously, you could alleviate alcohol withdrawal, and you could alleviate cravings for opiates as well. So most of that research and studies came out of South Africa in the 60s.
But a brief period or prolonged, or how long are you having to?
It just wipes the slate clean. So it's like, really? So I kind of heard about it. I mean, this started because I had a patient who came to me and said, I'm going to go do this brain restoration therapy in Louisiana. I was like, go ahead. I mean, like, is that like fairy dust and it's going to cure you? I'm skeptical, right? I mean, so they went, they came back, and I was pretty impressed. So I called this psychiatrist in Louisiana named Medier. I said, hey, I heard about this. How do you do it? And he's like, well, no, you need to come here. The Southern guy, you need to come here, you need to see how this works. Just do it.
And you did it, right?
So
it was
I was
more
like,
than just you got NAD.
So I went there. So I used
yourself.
my 1 week of summer vacation to go to the sweltering, humid back roads of Louisiana. And anyway, I was in this clinic with the psychiatrist.
Maybe that was the actual therapy.
Yeah, maybe. And anyway, what I saw there was really unbelievable. I mean, patients detoxing off high doses of methadone that, in the way we do it, they'd be crapping themselves in a corner. I mean, there's just no way. Then they were hanging out eating lunch, day 3, day 4. I was like, are you kidding me? And I kind of learned about the doses and the history, and I thought, on the plane back to California, I thought, this is going to change the world. And this is the real deal. So we started using NAD for detox in Los Osos in about 5 years ago. Turns out we've been like the oldest program now in the whole West Coast using NAD. There's programs now in San Diego and Portland and so forth. And there's some molecular biology of things that has to do with, histone deacetylase and changing the reaction of withdrawal state. But the reality is that it works very well. And the thing with opiate-dependent patients is that most people who are stable on opiates would like to stop opiates. They're not working any. They just take them now to feel normal, right? And they would stop, but the withdrawals are not tolerable. So, and when they've tried to do withdrawal on their own, it's not tolerable. It's just horrible. Or they're working, or they're mothers, or they've got jobs, So to answer your question, so my preferred detox is actually a program I learned about called brain restoration therapy. And what we do is we take 10 days, it's outpatient, it's an all-day continuous infusion of NAD. I mean, it takes anywhere from 4 to 6 to 8 hours, depending on how they tolerate it. But they're in a program all day, but it's a partial hospitalization level of care, so all day they have clinical programming. They have groups, they have individual therapy. It's just so the programming is the same as you'd get in a residential program, but you go home at night.
So they're being infused at that same time while they're home.
Yep.
So is something critical about IV versus?
Yeah, because you don't get
no
that. You can take
form?
it orally. You can take precursors to NAD. So NAD, if you take it orally, apparently doesn't work that well. You can take precursors to NAD. One of them is called nicotinamide riboside. One of them is called nicotinamide mononucleotide. And these are sort of B vitamin derivatives that have just recently been discovered, probably in the last 20 years. So you can take precursors and actually build up your NAD levels, and that's what we use after the program. So after people do that detox, we put them on some supplements. There's a pill, there's a nasal spray, and there's a patch that kind of keep NAD levels high.
So let's say it's a friend, relative using Vicodin or alcohol. So they would come in, and if they were highly motivated, would come in 10 days of this.
Yeah.
What's the and I don't know much about drug addiction or withdrawal or anything. At the end of 10 days, what do they look like?
At the end of
what
10
do they do at that point?
At the end of 10 days, they have no craving, they have no withdrawal at all. They walk away. If they come in on a short-acting opiate like Vicodin or like heroin. Now, if they come in on buprenorphine or methadone or these long-acting maintenance medicines, the days are different because they don't turn. It takes them longer for them to turn the corner.
So a couple of weeks.
A couple of weeks.
Okay.
And ideally, we actually do a washout with a shorter-acting opiate. But anyway, so I found that to be a very powerful tool. But the leading people in the world who are interested in NAD actually aren't in drug and alcohol; they're in anti-aging. So a famous Harvard scientist named David Sinclair discovered and published in 2012 some profoundly important work that showed that NAD influences these enzymes. It's called SIRT, the SIRT complex. SIRTs regulate transcription. So if you give NAD to mice, it reverses aging. It extremely slows and even reverses aging. This has to deal with like telomere destruction, because your NAD, so your NAD tens of thousands of times a day is being bombarded with oxidative stress and damaged all the time. And you have these enzyme complexes called PARPs, and PARPs read and repair your DNA, and that's NAD dependent. If your NAD is low from drinking, you don't have the fuel to repair your enzymes, which is why chronic alcoholics look like shit. They are prematurely aged at a molecular level. That's also fundamental, and actually it's linked to circadian rhythms, which is why they don't sleep well. It's linked to oxytocin production, which is why they self-isolate. So it's very interesting. So as I've learned about this, I'm like, oh my God, this is amazing. So, but that is expensive. I mean, the cash price for an NAD detox is $1,300 a day. So that's not in everybody's.
A day.
A day.
And that's not something, when you said you're doing insurance, but that's not something insurance
So,
touches because it's a.
well, so what we're the only program in the country, so what we can do is insurance will pay for a partial hospitalization program, which is because we're licensed, accredited, and so they'll pay for that program. And depending on what the insurance pays, that oftentimes is enough to cover that NAD, or a significant percentage of it. So say insurance will pay us $800 a day for a partial hospitalization detox program, then the patient would have to pay $500 a day. Or if the insurance pays us $1,300 a day, they wouldn't pay anything. That's kind of the nuts and bolts of it. But at the end of the day, if somebody comes in and needs detox and they can't afford that, I mean, our detox price is $250 just for an outpatient supervised detox. So I mean, it's not everything we do is that expensive. But that's the program that we have people come from all over the country to do this program. So that's called NAD. So you can kind of research it. It's pretty interesting, but it's really important for anti-aging and extending health and life extension. And those people are really about it because it increases muscle endurance, it decreases aging, it helps you sleep better.
So a lot of just people who are health conscious.
Yeah, just health conscious people will take it, and then they'll just take a supplement. They don't have to do the drip.
And how much is the supplement? Is that expensive?
You know, well, I'm always evolving on this. So you can buy a supplement online called nicotinamide riboside, which is a direct precursor to NAD. That seems to be the best way to take it. And there's lots of companies now that make that. Even there's only one manufacturer called Chromadex in San Diego, but everybody uses the same product. So that's the cheapest way to do it. And I kind of push people that direction. You can take pure NAD, but it's expensive. So
It's expensive in the U.S. mainly, or
well, because there's
anywhere?
one supplier. There's one supplier and one manufacturer of pure NAD. So like like for example, my wife and I use a nasal spray, and the nasal spray is like $130 for like a month of medicine.
And he's 90 years old.
Yeah.
Yeah, I'm really 90.
You're doing well.
But as you age, your NAD levels go down. This has been shown. Everyone who naturally ages, natural NAD goes down. There are some things that you can naturally do to increase NAD, but like stretching, fasting, and exercise, we know those three things increase NAD levels, which is probably why you feel better after a fast and a stretch. I mean, so NAD is one of the things we do in our clinic. But what I want to tell you is that NAD is very helpful for dementia, for Parkinson's, and for neuropathic pain. So we have people come in who, for other health indications, to try NAD. They don't do 10 days, they might do 3 or 4 days. But we've had Parkinson's patients and the tremor just goes away. Complex regional pain syndrome, used to be called reflex sympathetic dystrophy. That's like your body has an abnormal response to nervous pain, so you have extreme pain. There's no good treatment for that in modern medicine. I mean, there's things we use, but they don't help. And NAD, if it's the right type, can be a game changer for that.
Any link to Mucomist or NAC?
We use NAC in our detox program.
Okay.
We use glutathione and N-acetylcysteine.
Okay.
So for example, to give you an example, my wife, about 17 years ago, had a spinal cord injury from a horseback riding accident, and has a foot drop, and has every once in a while, like 2 or 3 times a year, she'll get this extreme pain in her leg, which is like she's just being electrocuted, especially if she gets like a bug bite, because it confuses your pain signals. Oh. She gets a mosquito bite in that leg, and she's fearful, like paralyzed in fear. Anyway, and then for about 24 hours, she'll get this debilitating pain. And my wife does yoga and rides a horse, and she's never taken a pain pill her whole life. And she'll just be incapacitated with this. So after years of doing this, I'm like, why don't you try NAD? I mean, I know it helps with pain, maybe it helped. Went away.
Wow.
So she takes NAD
literally
now.
this,
Like that.
or-
She did 2 sprays and it went away. So she does NAD now every day, and she hasn't had it yet. She's never had it again. So I think it's a generic. I mean, it's just a supplement that you could just have a compounding pharmacy get and make. So there's no proprietary ownership of it. So there's no big company pushing FDA approval to get it to be a blockbuster drug. So anyway, so actually the name of my clinic is actually Ken Starr MD Wellness Group, Addiction Medicine and NAD Therapies. So that's one of the really unique things that we do. But most of our patients, our day-to-day patients, aren't doing NAD. We do a lot of just standard drug and alcohol
So really,
stuff.
pain management places should be looking into this too. I mean, they basically, every
Yeah.
pain management that my
Right.
father's been to for severe back and my sister throughout the years, all they do is
Right.
compound drugs. It's
So in
more-
addition to NAD, there's been a lot of developments in knowledge now about pain pathways, like there's a pain like NMDA receptor antagonists, and this quinolinic pathway. So we actually have researchers we send our urine to of our NAD patients who are doing all these studies. But my clinic is on the cusp of providing some very innovative therapies to the Central Coast for pain management and depression that no one else is doing. So you're going to see some things in the next few months that are going to be big, that are only right now offered.
What's your take on fibromyalgia? Is it small fiber neuropathy or
I couldn't tell you the molecular basis of it, but I wouldn't. I mean, I would certainly try a few days of NAD because I think it helps with depression, but I probably would give them a few ketamine treatments too.
That's what I've heard. Yeah, there's somebody's wife who's always asking me the latest, and that was theirs was ketamine, and then this whole small fiber neuropathy relation or viral to fibromyalgia, and so it's interesting.
So we're in the next
So
few
you
weeks
use
we're going
ketamine
to
as
try
well
that.
in your-
No, we're going to.
Yeah.
We're just getting set up with some protocols and buying some equipment to do it.
Ketamine infusion.
Ketamine infusions, because I think no one's doing it here.
Right.
It's easy to do. So ketamine, for the unmedically initiated, is a medicine that has been around for a long time, and it, in high doses, I mean, it's used recreationally at raves because it causes euphoria and intoxication. We use it in the ER all the time. Low doses, subdissociative doses for pain control, higher doses for analgesia and for a dissociative sedation. Like, say you had somebody who was came in and needed to be intubated and put on a ventilator, you could just give them ketamine and the lights are on and nobody's home. Or like specifically in pediatrics.
It's a remarkable thing to see. I mean,
And in pediatrics, like say you have a kid with a fracture, a bad fracture, and you need to manipulate that fracture, you can just give them ketamine, and they'll just be like.
this is so in Haiti. This was my favorite medicine.
Yeah.
Like second to none, because you could just give a small dose. You could change
And it's safe.
dressings. you could-
IM,
Yeah,
IV.
IM. You don't need an IV. You don't need monitors.
It's
I mean,
great.
it's just injections.
So
patient
the
gets through it and-
last 20 years, it's actually proven to be extremely helpful for depression and pain.
Like
To give these
resetting
protocols.
the pain.
Yeah.
That's what this family was telling me, that it just
Resets.
their pain.
And specifically, and it's actually indicated for severe refractory depression, like people who are suicidal. You can give them a 40-minute NAD ketamine treatment and they're better. So we're going to start doing that. Because we're already set up as this infusion center.
Like, I mean, is that
Oh, is it?
narcotic?
Yeah,
Oh,
very
yeah, it's
controlled.
controlled, yeah.
Like a,
Yeah.
okay.
Yeah, you can't just.
Yeah, I mean, there's a black market for it for sure, but we're pretty responsible with our storage of medicines.
So could we venture into the social side of all this, where, I mean, basically, if you have a certain amount of money, you get this access to care. If you have that much money,
Well,
you
that's
get
true.
that access.
Because ketamine,
If
that's
you have
a cash
ton of
pay.
money-
That's not, right now it's not an FDA approved treatment that insurance is going to pay for. And some centers charge $600 a treatment, like a 40-minute treatment. And you need 10 treatments in
Yeah, they were
3 weeks or
going out
something.
there and one worked, but then it didn't.
Yeah.
They had to have another.
But here's what I learned. Here's what I just learned. is that there are a few big companies now that go around and get physicians' offices credentialed, to give them the policies, the protocols, everything, get them all set up, and they charge like 50 or 60% of your profit. So these centers are inflating the prices so they can make something and pay these guys. I think, knowing about what I know from the cost, I actually bought my first ketamine today.
It's cheap, right?
It is cheap.
I've actually looked it up. It's about $6 a vial.
Yeah, I would think that we could do an infusion for, $250 for a session. I can't see why it would need to be more than that. The only people who are doing it now is there's a big ketamine treatment center in LA. I don't know who else is doing it. So, but it does cost. You have to have a nurse, you have to be monitored, you have to,
Yeah.
So anyway, that's the wellness end of the practice, is like, why don't we use other things we know work if we can get people off of opiates and other things. So we're really interested in doing innovative, alternative, and traditional treatments. But if somebody has pneumonia, I give them antibiotics. I don't have any problem. I'm not just like a hippie alternative medicine guy.
Yeah. I mean, go ahead.
When I read somewhere about how they really affect, like when they prescribe Norco or any of those drugs after surgery, and they're made for, I thought, mainly post-surgery healing time, whatever, but then everybody says, well, I have this chronic pain. If you're in chronic pain, people, they say, I can't go today without it, because when I take it, I feel better. But are they really feeling better, or is it just a psychological thing for them?
No, I think they're feeling better. I mean, they're definitely getting back to, like you said, people just want to feel normal.
Yeah.
And it doesn't take a lot of narcotics to get you to knock down your own endorphin production.
But how could they ever, if you're really in chronic pain, can they ever get off of them? Or is it just...
Yeah, you can, but as you become opiate dependent, your chemistry physically rewires. I mean, it physically rewires such that you need that medicine to feel normal. So there's a very real dependence on that. That's irrespective of bad behavior or poor judgment and whatever. So yeah, the people need to take that medicine to feel normal. They can't get off it. The other thing that I wanted to say before I forget is there's something called opiate-induced hyperalgesia, where the longer you take an opiate, your brain resets to that level. It works less for pain. So actually, things become more painful.
Yeah.
So things that before weren't that painful are now extremely painful. So everyone who says, I have a high pain threshold, who's on chronic opiates, has no pain threshold, right?
Yeah.
Yeah.
I often use Haldol now in chronic
Haldol, that's a
pain.
psychotic drug.
Antipsychotic.
Yeah, because you'll have patients who are just writhing and making noise and going crazy in the room, and it's shocking to me, like a single dose of Haldol, where it's almost like you're disconnecting, the brain from.
Why wouldn't you give them ketamine?
Why would I?
Wouldn't you?
The nurses are
Yeah.
more comfortable with Haldol. I mean, ketamine
Only because you
is
don't have
like
droperidol anymore.
What's that?
Only because you don't have droperidol
Right.
anymore.
But
What did you say?
It's FDA approved, right? Are you saying it's not?
Yeah.
Because
No, it is.
FDA, no, for use in the ER and stuff. What he's talking about is
So if you give somebody a dose of Haldol, that's sort of, okay, don't let them drive, kind of thing.
Yeah.
Well, with ketamine, you can turn them into, they're just staring off into space for a prolonged period. So, anyway, the nurses definitely seem more comfortable with a dose of Haldol to settle somebody who has acute abdominal pain or whatever it might be.
You use pretty low doses for pain and nausea, don't you?
What's that?
Use pretty low doses for that.
Haldol, I use 2.5 milligrams usually, rarely 5.
So that's a big slug. Haldol, that's 5 milligrams IV of Haldol?
Oh yeah, no, it definitely gets
that's
you
a
through
big
the
slug.
night.
What's with this Precedex I just heard about?
Precedex is not an ER drug, it's an ICU drug for sedation to manage patients who are ventilated.
Okay, because I got
Isn't it?
EEG on Precedex sedation mimics normal sleep, supposedly doesn't interfere with EEG, and it's the first time I've seen this. Oh.
I mean, it's a sedation drug that, I mean, we don't use it in the ER, but the ICU uses it.
I hear them using it, but
It's a sedative. It's like, phenobarb, or I imagine it's not because it doesn't affect EEG. It must be like propofol or something.
Propofol horribly affects EEG.
Yeah.
Even when you turn it off and they sort of wake up, it's still just
Yeah.
all
I've never used Precedex.
It was-
Yeah.
They use it historically for alcohol withdrawal, severe alcohol withdrawal in the ICU.
But they did, Sierra did an MRI and EEG with Precedex sedation.
Oh, okay. Maybe it's probably better.
It's the first I've ever heard of it. So.
yeah. For me, I actually think that like my universal health care would amount to almost one thing. I mean, maybe vasectomies too, but I mean, I would love for the government to focus on addictions, because I view every medical problem as having a blast zone. So, you know, if you have a laceration, all right, that's, you know, pretty local blast zone, but people with addictions impact just so much around them. And if you can attack that one problem, I mean, it really can radiate socially a huge distance. And so I you know, I wish if somebody is watching that that can make legislative changes, I'd love for
there have been
NAD, ketamine. Like, I think these things, I would love it if that was funded.
There have been some. I mean, the government now recognizes it and is putting some money towards it.
There's huge changes, but it's not fast enough for me.
With the pain pills that they're getting monthly, so they're still getting. I mean, my sister has to go in every single month, so she's still getting a chunk of them. Plus, she has 100 stockpiled, I think, too, from the past where they weren't doing that. But so, you know, he's her regular doctor every single month, and he know. I mean, you're looking at her, he knows she's addicted.
Yeah.
Yeah.
I mean, you know, she is in chronic pain.
Well, you know, all you can do is just set up a patient contract. Say, okay, well, here's how many you get. I'm not going to fill it early, and stay within the program. That's all you can do at that point.
What is it considered abuse? Like, how many Norco is somebody allowed to take a day before they would?
We actually worry more about the Tylenol aspect of it. So
That's
yeah,
the worst
if you
part.
keep adding Norco, then you're getting probably way too much Tylenol in there.
So that's
It's
the
considered.
acetaminophen part.
It's considered abuse when you have negative consequences from its use and you continue to use, and if you are, like, say, you're running out early. So my guess and my experience with somebody who's been on long-term pain pills is almost all of them are running out early at that point, because they started on 3 a day and now they need 8 a day to feel normal. So they're burning through their prescription in 2 weeks instead of 4 weeks, and then they're buying it on the street for 2 weeks and then seeing their doctor. That's my guess.
She doesn't do that, but it's just that physically you
Yeah.
just can see the difference in this
Right.
person who has aged
Right.
in the last 10 years, like you were just saying. I mean, she looks as old as my 90-year-old father, and
Right.
she's 67. You know?
Does she have an exercise routine or anything along those
She's a
lines?
drinker?
She won't do any drinks too.
Yeah.
Yeah.
So you can imagine. So that's a high. So if you're on opiates and you're a drinker, even a moderate
It's a
drinker,
hard combo.
They're not eating.
you have
Right.
you have a severe energy
She's always
deficiency
sick,
state.
She's always
Yeah.
nauseous. She's always, you know, and
Yeah.
there's always something, and she just gave up with the pain in her hip. Gave up trying to rehab it, and it was a bad hip surgery that went bad, and it was never able to be repaired in 10 years.
You know, and this is the funny thing is that this is completely a first world problem, right? So the United States uses like
We consume
90% of the world's opiates. 90% of the world's opiates, and we're 5% of the world's population. So this is totally a first world problem. Other places, I have a friend who is an ER doc who did a few months in India just for fun, just, you know, the human experience, and they never used any opiates for anything. Post-surgical, acute pain, broken bones.
Severe pain.
Right.
Nothing. There's no morphine for everybody for everything.
Well, it's for a time. So I moved here from Albuquerque in 2012, and the decade before that I spent working on kind of a similar direction.
You started a program there?
Yeah, it's called Endorphin Power Company. So we tried to get people to exercise as a mechanism to use less narcotics, drink less, and you know, improve the community as well. But something that struck me there that I learned in the social dynamic is, you know, you pick somebody up because they've broken a law, they're addicted to heroin, you go into jail. They made methadone available to these people for free in jail. When they leave jail, then they're stuck with basically a methadone addiction now, which is actually harder to kick than heroin, and a bill. So, you know, it was costing them, these people who leave now have to pay $7 a day for whatever dose of methadone, and the doses just go up and up and up. And I remember hearing a methadone, I guess a methadone pusher equating methadone to insulin. So saying, you know, narcotic addicts are, you know, it's a disease where they have to have this narcotic. And so this person was definitely making money on methadone. It really, you know, irritated me at the time. I know that it's not the case that, you know, people can get off methadone, people can have normal lives again, and it's just not diabetes, it's not the same as being,
But
you know,
also,
dependent on
they're
insulin.
pain. They're going to give my 90-year-old father methadone now.
Well, there's a certain point where, like,
He's miserable because he
Yeah.
can't do anything anymore with his back and the failed back and all this stuff. So now they're going to try methadone because
Well.
nothing else is working.
Well, it's a good pain medicine for long-term chronic pain.
It can work. I mean, it's
Yeah.
no, no, it will, yeah.
I mean, he'll be opiate dependent.
At this point, we all kind of said,
no, he's,
"Not
yeah,
anymore." He's so miserable.
that's not a person that I necessarily would say, you got to get off your
Yeah,
methadone.
like I had this guy come into the clinic who was like in his late 80s, probably early 90s, but drives himself. He's pretty with it. Who has been on pain pills for many years, and his wife died, and he was just really depressed, and he came into the clinic, and he's like, I've been on these medicines, I've been on these pain pills, and I've been reading all these newspaper articles. He gave me the articles, look, and I'm supposed to get off of them. I'm like, he's like, I mean, how many are you taking? He's like taking 2 pain pills a day or 3 pain pills a day or something. I'm like, am I going to detox a 90-year-old guy? It's like, are you okay? Yeah, they work. Yeah. Are you having any problems? No. I'm not going to fix this. You know what I mean? I'm going to put him through acute withdrawal and detox him because he shouldn't be on them.
Somebody said you should not be on it.
Yeah. So, but then his doctor wouldn't prescribe it anymore.
Yeah.
His primary care doctor said, well, I'm not going to prescribe these medicines for you anymore. So he's the only guy in my entire practice who I just write for his regular pain pills because no one else will do it. I thought, this poor guy, he's the nicest guy in the world. Like, just cry when you hear a story.
And if it's not affecting him,
Yeah, right. He's not abusing it. He's not. I mean, is he opiate dependent? Absolutely. Is he a drug addict? Does he have addiction? No. Addiction is those negative consequences, right?
Are we gaining on this problem? There's all this talk in the newspaper, which is why I wanted to come. What's really the story? But we all had to do continuing ed on pain management a couple of years ago, and all this talk. Are we reducing it? Have you seen a shift in any direction?
I think so.
I believe
I think so.
I think
I mean, the
so.
numbers actually,
Yeah.
I mean, the overdose numbers aren't totally turning around, but they're leveling off.
But I think that that's a delayed effect.
Yeah.
Well, one thing I should talk about with our ER is that before I came here, apparently there were a lot of patients who were frequently coming in needing opiates. They do a care plan now, which is hugely helpful. Yeah, so if there's somebody
together
that
better.
is using
frequent flyer.
Yeah, frequent flyer, that's the term.
come in because they're coming before they're
Yeah,
getting you guys.
basically a care plan gets put together where, if we can see a binder and open it up and say, this is what we will do for this patient, so that everybody's consistent. Because one of the problems is that, he may prescribe 10 Norco and I may prescribe 20. And each day you come in, you get a different experience. One thing I can say is that, cures, and I work out in Hawaii sometimes, I get these notices on occasion about patients who have, are abusing. And, 10, 20 different doctors, and I'll see where I am on the spectrum. So I give 10 Percocet when a patient has their dental pain to come in. But you see these other doctors and they're giving 180. So I do think that those notices hopefully are giving feedback where doctors see where they are on the spectrum. I don't think a lot of primary care docs know what's normal or not. I mean, there's a pressure to prescribe a bunch so that don't have to come back every 2 weeks. And from the ER, I think we have a better. In fact, there's an article that just out about it now that ER docs tend to prescribe less, 10 to 20 of a tablet.
I think it's slowly improving. I think the cure system, I think the reclassification of some medicines, the drug-deterrent formulations of some medicines, the scrutiny that the DEA is giving providers who are high utilizers. And then it's swinging back from the pain being the fifth vital sign, that's going away.
Oh, interesting.
Yeah. Because that was all industry-sponsored nonsense. I mean, that was Purdue that created that.
Can you give this to mommy? Give that to mommy.
So I think it's getting a little better.
I'll take care of him. Vanessa, I'll take care of him. So she actually has to drive her mother. That's okay. This is, that's fine. But so maybe one of the a couple more questions. So when someone in the ER shows up that has no money and they say, I want to not do this anymore, what do you tell them?
Well,
Public health, or is there a way that they can work it?
well, I had a patient in the ER the other day who had been a patient of mine, who was kept relapsing, who I just said, just come to the clinic and we'll just take care of you, no charge, because he had already, I kind of already knew him. But for the general population, I mean, we just have to refer them to the, the county and methadone clinics.
And does the county offer a lot? I mean,
well, the county will take Medi-Cal to pay for all their medicines and care and programming.
Yeah.
What's the success rate of the county program, or of any program, really?
Well, with
Right.
opiates, it's terrible.
Yeah.
I mean, the relapse rate with opiates is 90% if somebody does acute detox. 90%. So if you come into a residential program for acute opiate, chronic opiate use, and they do a detox, 90% of those patients will relapse in a year. So it's very high. I think our numbers, I mean, I like to think my numbers, like using NAD, are about 40%, but it's more like just, the continuing care and support and programming that people need for recovery.
Now, you had mentioned
I think it's
AA versus other programs. What is your take on that? And what is the controversy? What would people be saying?
Well, the controversy. I support AA 100%, but I think AA is a sober support organization. I don't think it's it is a method of detox. I think you should detox people safely with medications, and then I think AA is a good tool for sober support. So the critical writings that have come out recently have said that when you really look at AA success rate measured scientifically, it's not that good. But the truth is that millions and millions of people have gotten sober from AA.
Yeah.
So why not? It's a social. I mean, it's great. It's fine. If that works for you, it's great because it's cheap.
I think anything that limits isolation is a helpful step. I mean, what we used in our program in New Mexico, we kind of created electives. So not one thing works for everybody. Some people need religion, some people need medicine, some people need, AA. And so we basically said there were 4 pillars. It was education, exercise, community, and service. That was our, we had a transitional housing.
Just giving back.
Yeah. Helping other
service.
people. Right. And we're at a spot now where people are left the program and really seem to have benefited a lot from it. But I don't think that there's any one solution that will just solve everything for everybody.
Such a complicated disease, and and statistically, the vast majority of anybody with a substance use disorder has a history of trauma, emotional trauma, abuse, neglect, sexual assault. I mean, deep emotional trauma. In fact, I've heard some experts say 100% of people with a substance use disorder have, emotional trauma.
The person who affected my view on alcoholism the most was my grandfather, and he drank for years after the war. He was in the Navy, and that's where he practiced his drinking. But when he moved from Boston to New Mexico, he was done, and he continued to brew brandy for friends. So this was a guy, he didn't do AA. He said he could, he would chase antabuse down with beer. Like there was, he's an unusual guy. But to me, I think environment is as much of a factor as anything. So if you can just take somebody and create more nurturing friendships and connections, then that can be as effective as anything.
And there's that famous guy, what's his name, who did that TED Talk that said the opposite of drug use and intoxication isn't sobriety, it's community.
No, I didn't hear that. Yeah, I
Was
was.
that Rat Park guy? Have you ever saw that?
Which one?
The Rat Park.
Don't know. Yeah.
Well, this is these experiments where they, you've probably heard about this. These guys put rats in a cage and they gave them water or sugar water or cocaine or whatever, and of course the rats just self-medicate with cocaine and drugs. But so their proof was like, oh, you see, people prefer this. But then this other guy said, well, let's change that experiment. They can do the cocaine or drugs, or we can have this awesome rat park with the best rat tools. And
Rat Park.
Rat
I
Park.
thought you were naming somebody.
No, like it's a rat.
Okay.
It's a rat haven, like wheels and colors and cool. And his argument is like,
And they were into it. They were like, this
they
is
didn't
life
use the
is worth
drugs
living in
because
this
they
other
just liked the community of being with other rats.
Yeah.
So that's kind of his analogy, is like if you give people an outlet, exercise and service in the community, they have less, you know.
Now compare Oreos to the drugs.
So yeah, but not anything works. I'm really kind of appreciating the whole genetic blueprint of addiction, you know. Like when people take.
But how
like,
did you, so compare you versus your brother? Like you grew up in
well,
different,
me
in
with
the
my
same
brother,
setting?
well, he was my stepbrother actually.
Oh. All right.
Yeah, so he had a different father. But like when most people take a pain pill because something hurts, it helps the pain, and the pain goes away, and they stop the pain pill. If a different person takes a pain pill and they feel great, like wow, I feel energized, I feel no fear, I mean just wonderful. That's an abnormal response. That's a genetic abnormality that predisposes that person to addiction. And it's the same thing with alcohol. My brother who had Lifeline. So like I can drink a beer. I don't have any problems with beer, you know. I'll go home, have a beer, maybe two, possibly if it's early enough and I'm not gonna ruin my sleep or whatever. But you know, I like it, but you know what I mean? It's like, I don't love it. But certain people who drink and it is great. It is perfect. Like this is how I'm supposed to feel. That's someone who's genetically wired for alcoholism. So that's just genetics, you know? And so the difference was when I was in high school and junior high school with my brother who's a year older, I mean, we were smoking pot and drinking beer and doing everything else that everyone else was doing, but like, I could walk away from it. I mean, it's like, I would felt better when I wasn't drinking or smoking. So he didn't. So that just progressed to opiate use, and you know, then it's just inevitable. Then it's a very progressive disease process, just like diabetes is a progressive disease process, right? With neuropathy and blindness and blah, blah, blah. So is opiate use, so is alcohol. It's a very progressive thing, very progressive. So that's why it meets the criteria of a disease. It's progressive, it's predictable, it's treatable.
I grew up in fear of alcohol because of my grandfather.
Yeah.
And to this day, my mother will still say, you know, you have the gene.
Yeah.
I've made it this far, Mom. Never, you know.
Yeah. Well, that's not true.
It's not true that, I could still become an alcoholic
Absolutely.
today? Okay, well,
I told all my
I'll still
girlfriends.
steer clear.
I have a lot of people who started
I
drinking.
don't enjoy it. To be honest,
Yeah.
I'll drink a beer. It's like, okay.
Yeah.
But I don't have that
Yeah, so it's unlikely.
uplift that
There's so much
you describe.
pressure, because I drink, this much wine once a year. Well, why don't you want to drink? Well, I don't know. I'm not
So,
thirsty.
but there's two ways to get there. One
drink
is you're
all my wine with
genetically,
Kathy.
one is you're genetically predispositioned, like you just start. I have people who started drinking when they were 14 and never stopped, and you have people who, they started drinking kind of socially after work, and then it just became a habit where like they have a glass of wine, have a glass of beer. Then it really kind of relieved anxiety. So then gradually they kind of just drank more and more. So that has to do with the molecular biology of addiction. So when addiction starts, it's called positive reinforcement, meaning I drink or I take drugs and I feel better. That's positive. Like I do this, I get that response. I like that. Once you're adapted to the point where that's now pretty regular, you get what's called the negative stress circuit, where if you're not drinking, now you're anxious and feel worse. So now you're doing that to feel normal, to avoid negative consequences. So anyone with a severe dependence or addiction, it's not the positive reinforcement anymore, it's the negative. So all my patients who are drinking and are opiate dependent on a regular basis, none of those people now are they're just doing that to get by, just to get through work, just to feel normal. They're not doing it to escape. Oh yeah, I had a 30-year-old guy yesterday who's just nursing vodka all day just so you can get through work. Drinking like a fifth a day or something.
I don't know how it's physiologically possible.
Yeah,
like
it's crazy, isn't it? Like you look at that and you're like,
And they drive and they can drive.
he's running a restaurant downtown.
You wouldn't want them to,
Drive your children.
yeah, or to suddenly stop and then go drive too. It's it's a hard.
But it's a challenging and rewarding job.
Oh no, I mean, yeah, if you help somebody to stop using, that is a huge benefit to. They'll just, it
we do.
feels good.
We do it. We have a lot of success stories in our clinic for sure.